I'm sorry about that. Thank you for the welcome. Yes, I'm an orthopaedic surgeon in Sheffield, in the UK. So, my next slide just shows my disclosures. Sheffield is quite a big city, 600,000 population, serving a larger referral area. We're about halfway up the island of Great Britain. It's an ex-industrial city, home of stainless steel, and next door to one of the world's busiest national parks, which provides us with quite a lot of trauma, and therefore, over the years, I've had quite a lot of experience with dealing with avascular changes within the talus. And I'm sure, like all of you, the way that I've treated that has been through the well-documented procedures that we've all used. And that is to excise the diseased area, either perform a tibia-calcaneal fusion with a plate or with a frame, and plus or minus a lengthening procedure. Again, not very well tolerated, you end up with a short limb, and there are issues. I've also tried bulk allograft with femoral head, and that can be successful, but we know from papers that there are about 33% chance of that graft resorbing and collapsing. And I've also used off-the-shelf spacers, as you can see on the right-hand side of my screen, but even those have been withdrawn from the market, and of course they're not perfect because you have to make the defect fit the spacer rather than actually treat the pathology to hand. So my experience has been over the last 6 or 7 years of using patient-specific implants, and this patient here with avascular disease changes to the body of his talus presented with unremitting pain for a year. And the CT and the MR shows that he has quite advanced collapse of the body of his talus, with principally changes in that area and affecting both the ankle and subtalar joint. So with him, I went through the process of manufacturing an implant specific to the pathology that he faced. And you can see here this sort of keystone-shaped implant that's loaded with autograft and is cannulated to accept the nail. And he's now pain-free and walks about 8 miles a day. But the problem is that although pain relief is good, you do lose function when you have such a large fusion mass. So it's always raised the possibility of total talus replacement. And there is some history behind this, and this is really where I became inspired, because this gentleman from Thailand, and I'm not going to try and pronounce his name because I won't certainly get it wrong, published a long time ago, 25 years ago, about his experience with body replacement of vascular necrosis, but also for trauma. Really quite a genius of a gentleman, because he used slit scanogram measurement techniques which were of their era, and he effectively made a last of the diseased area out of stainless steel, the peg that was supposed to sit in the neck of the talus. And then what he did is he ground out the shape of the talus on the block and then polished it so that he had an implantable device. That's an awful lot of work for your patients. I was very impressed. And his experience was published 25 years ago, and he started this in 1974, but he had concluded that he'd had quite good outcomes from this over time. And you can see there's a long follow-up period, and he revised 2 of them. What I can only assume is his son or daughter that then took on the mantle, published again in 2014, and they published on their experience of 36 talar body replacements up until 2011, using the same manufacturing technique, broadened the indications to include a couple of bone tumours. And although they lost 3 of their patients to follow-up, they had a very lengthy follow-up period. 5 of them were revised, 1 for collapse, 1 for infection, and 1 for bone tumour recurrence. And the way they were revised were to arthrodesis and revision of the prosthesis. 1 patient had a transtibial amputation. So I think that this was probably the inspiration behind this Japanese gentleman's experience that was published in 2012. The difference is that he used a slightly different technique using CT, and he made ceramic implants of 2 generations. Again, these were body implants, not total talus yet. And again, generation 1 had a peg in the neck, generation 2, there was no peg in the neck. He did 22 of these and followed them up for over 4 years. And essentially his first generation ones all became loose, and the head of the talus necrosed. He then subsequently had to revise these. The second generation of those were 14 of them, and 4 of those were revised to total talus replacement. So in other words, he had 6 that he revised onto total talus replacements. And as a conclusion from that paper, he suggested that actually this should be a primary source of treatment for this condition. So it added effectively something to our toolbox and was inspiration to me. And I've only done 3 cases, but I think you have to be very selective. So one of them was for a whole talus AVN, one was for post-talus collapse after a Hawkins 3 fracture treatment, and one for fibrous dysplasia. So this is the first case. As you can see here, CT and MRI shows complete involvement of the avascular necrosis within the whole bone, and there is an awful lot of fracturing. Thankfully, none of the joints were involved, and that was the inspiration to consider total talus. So what we did was we designed a cobalt chrome implant based on contralateral talus. We made 2 sizes, allowing for some sort of discrepancy measurement over CT, and through an anterior approach, essentially I perform a cruciform osteotomy of the dead talus, a bit like a trapeziectomy, and then remove everything in small chunks, taking care to not damage the articular surface any further, and then implant the talus. And what you're left with is great pain relief, still an excellent range of motion, and some very bizarre x-rays, but actually very gratifying in terms of what you can achieve with your patient. The second case was a gentleman who had a motorcycle accident in 2018, had a closed Hawkins 3 fracture which was fixed, and you can see that he's gone on to avascular necrosis. He came to me having had the metalwork removed, no history of infection, and clearly avascular changes throughout the body of his talus and also into the head. Slightly worrying was, on the CT, I picked up the fact that he had a non-union of his sustentaculum talus, but I decided to plan for that just in case, and I was going to do a subtalar fusion, but in the event, I was able to simply treat this with a total talus, because when I implanted the talus, it was nice and stable, and I didn't feel that the non-union was going to contribute to any instability. The third case is a 16-year-old female. She had 3 years of pain from the fibrous dysplastic changes within the whole of the talus, and they waited until she'd achieved a skeletal maturity to consider further surgery, because the options that had been put to her were very much about those I described earlier, to consider talectomy, tibiocalcaneal fusion and lengthening, and that really wasn't tolerable for this young lady at that particular time in life, and to a certain extent I don't blame her. So you can see on the left here, again, that cruciform osteotomy to take out the dead talus and then to fashion a talus that fits in its place. Slightly different changes on this talus, reflecting the fact that she had grown with slight abnormalities of the morphology of both the tibia-talar joint and the subtalar facet. But she's gone on to be pain-free, and to be fair, we haven't burnt any bridges, because we can always go back and do what would have been a traditional treatment in due case. So, where is the evidence for doing what we're doing? It's there, but it's not much. There's this seminal paper again from Taniguchi in 2015. He did 55 ceramic total talus replacements with 4.5-year follow-up. None of his have required revision, and he noted all improved pain scores and they all returned to work. Anish Kadakia published in Foot and Ankle International in 2020, and this I think is the Duke experience, combination of 27 total taluses, a mixture of either cobalt chrome or titanium nitride coating implants, followed up for just less than 2 years, but noticed the significant improvement in pain scores. But they did have one deep infection and went on to transtibial, and one conversion to hindfoot fusion. So together with Andy Goldberg in Sheffield, our fellow has performed a systematic review, and we have identified 9 studies with this number of patients that have had total taluses or body talus replacements, and again for the same indications that you have seen already. And what we found was that these things seem to last. In other words, their survivorship is pretty good for the time that they have been in, and they have very good significant pain relief scores from pre to post-op, and all other scores demonstrated some improvement, but they didn't reach significance. So I put it to you that this is a technique that is of some promise, and the early evidence suggests so. We will continue to learn how to use this as a technique. I think it's really important to stress that you have to assess your patient very, very carefully. You have to counsel them as to what you are doing. You are slightly experimenting with them, and they need to know that, and they need to travel on that journey with you. And therefore the consent process has to be extremely rigorous. I think for all of our benefit, post-operative monitoring and scoring is going to be hugely important, and that will generate the evidence that will come with time. And I'm sure that we'll be talking about this more often as we go through the next decade or two. Thank you.